HPV vaccination. So, for a small detail about HPV, so it's a virus spread by intimate skin-to-skin contact. So it's mostly sexually transmitted, but people who haven't had the course also can become infected. There are more than 150 types of HPV virus, and most of them cause genital warts. So about 80% of people, both men and women, will get an HPV infection at some point in their life. Most people will not know they are infected because of the immunity can go unnoticed and will never show up unless they become immunocompromised in the future. But for some, the infection persists and can lead to precancerous change. So this is the how the HPV virus gets integrated into the basal cell in the keratinocyte layer of the squamous epithelium. And the various proteins like L1, L2, EC7, they are all implicated in this HPV integration. And when this infection undergoes mutation and there is immortalization of E6, E7, the E6, E7 oncoproteins, they inhibit P53. So when it happens, it becomes interrupted in the lesion and goes for cancerous change. So this is the pathophysiology. So there is an initial subclinical HPV infection which will go unnoticed, and then the replication will occur, and then there will be suppression of warts in some patients. Some patients even then won't be visible. Then the expression of E6, E7 protein, so that inhibits P53 and RB chemosuppressor, and the infection is persistent now. So the infection can get cleared. It can progress to CIN or small and ectopical lesions, and then it can get cleared. But for some, it gets invasive and leads to cancer. So these are the benign lesions. So the common warts, flat warts, filiform warts. These are all benign HPV lesions. So there are a lot of genotypes. It can be two. HPV is usually mucosal or cutaneous. So mucosal lesions are usually anal cancer, cervical cancer, oral cavity cancer, and vaginal cancer. And cutaneous lesions are all warts. Some forms of psoriasis also due to HPV. Then lichen sclerosis, keratoacanthoma, varicose warts, these are all cutaneous lesions. So the genotype HPV 16 and 18 are cancerous. They are high risk and can cause cervical, penile, oropharyngeal cancers. And there are benign lesions, benign HPV 31, 33, 35, 39, these are all low risk and cause cervical squamous cell carcinoma, and 6 and 11 are benign warts. So this is about the natural history of cervical cancer. So there's a normal cervix, it gets HPV later changes, it can become low-grade squamous interrupted lesion with atypia CN1, and 50% of this progress to high grade. And from high grade, if early identified, it can revert back to a normal cervix. If not, it can progress on to invasive cancer. So for cervical cancer, due to HPV, what are the risk factors? So behavioral risk factors, early coitus, early menarche, then early first pregnancy, then there is smoking, multiple sexual partners, OCP use of more than 5 years, high parity. And socioeconomic risk factors, with limited access to healthcare and low socioeconomic status, low education status, and poor knowledge. So genetic factors, altered immune response, and public health, and there is low awareness about HPV vaccination and low screening. So this is the HPV infection. So in transient infection, the cervix may appear normal or can have a CIN1. So this can get cleared and then can regress. But when it becomes, the viral load becomes persistent, it becomes precancerous lesion. Precancerous lesion also can be treated early. If not, it progresses to cancer. So this is the HPV during pregnancy. So in cervix, the prevalence of HPV, when you're screening, the sample size in cervix, there is almost 30% chance of HPV infection. The placenta 17%, and serum 32%, amniotic fluid 2%. So it can cause preterm labor and can cause IUGR, but it's too controversial. Sometimes it may go unnoticed. So about HPV infection and cervical cancer in India. So Indian scenario, this is how the vaccination for measles, diphtheria has reduced the incidence and prevalence of the disease. So the HPV causes more than just cancer. So these are the cancers which can be due to HPV. So percentage. So on the global percentage, cervical cancer due to HPV amounts to about 100%, vaginal cancer 70%, and vulvar cancer 43%. So in oropharyngeal cancer, there is also about 13 to 56%. So other can be precancerous lesions like papillomatosis, warts, can lead to many benign lesions also. So worldwide burden, in worldwide burden, the vaginal cancer tops and followed by cervical cancer. But in India, cervical cancer is more compared to vaginal cancer. So in India, there is a high incidence of cervical cancer, followed by vaginal cancer, then anal cancer, and among this, HPV infection, due to HPV infection, 6.6%. So cervical cancer is 100% preventable when treated early and vaccinated early. So the majority of Indian population are unvaccinated and they don't go for screening. So this is a pyramid, and primary prevention is important. So when in the West, due to increased vaccination, the incidence of cervical or vaginal cancers has reduced by 70% and the deaths has also reduced by 80%. So this is the WHO global goals that are sustainable developmental goals for 2030. So by WHO recommends 90% of women, of girls under 15 years of age to be vaccinated, and 70% of women who had to be screened at 35 to 45 years of age, and 90% of women should be identified with cervical disease and treatment and care. But in Indian scenario, vaccination is 0 to 0.1% only. And the screening also is done only for 3% of women, and the identification of cervical disease in early stages also only 10%. So by 2030, the Western scenario is they are almost reaching 90%. So they go cervical cancer free by 2030. So for India, this, we have started vaccination, and so also vaccination of girls at 9 to 14 years of age is included in the vaccination schedule these days. And also including vaccinating boys from 9 to 14 years of age by the HPV vaccine. So in the private sector gynecologists, we have to help to make the patients aware of the cervical cancer vaccine, HPV vaccine in the future. So risk of HPV infection across different women at 15 to 45 years of age. So these are some examples of women who have died of cervical cancer at a very young age, at 26 age and 28 age. These are all women. In India also, there are celebrities who died of cervical cancer at 40 years of age. So these are all the incidents, the HPV incidents in the screening. So incidence of cervical cancer starts at 30 to 34 years of age and it increases up to 54 years of age. Then it becomes decreases. So new cases, if screened early, can be identified early for progressing to cervical cancer. So almost 24 average years of life lost to women with cervical cancer. So in India, the median age of first sexual intercourse among women at 20 to 29 years of age is reported to be 19.1 years. So because of early marriage. So engaging in sexual activity at a younger age has been linked approximately twice the risk of developing HPV-related cancers and disease in the future. So at the rural side, this is very common, the marrying of young girls at 18 years of age. So counseling is undergone by PHCs. They usually give counseling to those rural places, but still it's going on. So 1 out of 2 women may be at risk of HPV even with a single partner. Even if they have a single partner throughout their life, they are at the risk of having cervical cancer. So by study, on an average of women who engage in sexual activity report in India is they have 1.7 lifetime sexual partners. So in India, only 0.4% of women are exposed to all 4 prevalent serotypes of HPV. That is 6, 11, 16, 18. So if vaccinated, more than 99% of women can be help prevent cervical cancer. So what about a pregnancy? So during pregnancy, they are the high risk of getting HPV infection. So postpartum due to multiple vaginal deliveries, injuries to cervix during vaginal delivery, thickening of cervical epithelium, cervical ectropion. These are all risk factors which increase the risk of HPV infection. So during delivery, during the antenatal period, so 1 to 3% of women diagnosed with cervical cancer are pregnant or postpartum at the time of diagnosis, and 50%, about half of these cases are diagnosed antenatally, and the other half around 12 months postpartum. If they are screened actually, 0.70 to 1.67 incidence of abnormal cervical cytology finding during pregnancy. So 45 to 50% of pregnant women are at risk of high risk HPV infection, and 31% of postpartum women are at risk of high risk HPV infection. So preventing cervical cancer with HPV vaccination. Combined cervical cancer screening along with vaccination can reduce the cervical cancer risk of up to 63%. So these are the safety profile for quadrivalent vaccine and monovalent vaccine has been studied, and in 2006 quadrivalent vaccine was approved, and in 2014 monovalent also was approved. So the side effects caused by both the injections were only injection site reactions and headache. There were no anaphylactic reactions or no very high intensity adverse effects was not found. So if females and males at 9 to 15 years of age were vaccinated, they resulted in 10-year study. There were 0 cases of genital warts or high-grade intraepithelial neoplasia. So the vaccine was 100% effective with more than 95% seropositivity. And in females at 16 to 26 years of age, when they were vaccinated, there was also 0 cases of CAN3 or AS, cervical or vulvar vaginal cancer, and there was also 100% effectivity. So this is the effectiveness for HPV and for quadrivalent and monovalent. So both were all effective, and the antibody responses was good for both. So it was almost equal for HPV, monovalent and quadrivalent both give the same antibody response. So this is a study, future study. So in the future study first group, the study was done between women 16 to 24 years of age, and the vaccine efficacy was 100%. So the vaccine was efficacious against 6, 11, 16 and 18, all related to CN1. So the next group between 15 to 26 years of age, the vaccine efficacy was 98%, and they had a low risk of getting infected by 16 and 18. And for 24 to 45 years of age, the effectiveness was 90.5%. The efficacy reduces after 24 years of age. But the risk of precancerous lesions, it reduces. So, the monovalent vaccine, this was also the immune response from both quadrivalent and monovalent was almost the same. The quadrivalent is not much inferior to monovalent vaccine. There was So this also the same. There was a 100% effectiveness when given at 16-23 years of age. So this is among after 25 catch-up vaccination for women after 24 years of age. They included vaccination and screening, and there was 88.7% effective. And in seropositive, in already affected women, there was 66.9% effectiveness with vaccination. So regarding vaccination during the postpartum period, so the majority of women, there was a study conducted, and the majority of women reported a high degree of satisfaction with postpartum vaccination, and more than 80% of women were elected to make a separate visit for vaccination. That is, during discharge they were vaccinated, then they wanted to be vaccinated during discharge. They didn't want to make a separate appointment and then come and get vaccinated. So the study was made to say that during discharge itself we had to vaccinate the postpartum women. So there was no serious vaccine-related adverse side effects. Only injection site adverse effects like erythema, pain and swelling were responsible for the increase in adverse events. So many women, because of this, they were hesitant to get the second dose. So counseling and vaccination opportunity in gynecology practice. So we gynecologists see women at 27 to 45 years of age majority, that is during pregnancy. So at this time we have to counsel them for vaccination. So So if when awareness about HPV and its vaccination is in India is very low. So when pregnant women were they were studying in Bangalore, they only 38.7% were aware of cervical cancer, and only 5.33% were aware of HPV vaccine, and they only 8% knew that HPV is the cause of cervical cancer. So this knowledge gap we have to counsel them when they come to OPD so that they will be more aware of the vaccination which prevents cervical cancer. So the perinatal period and the postpartum period provide an excellent opportunity for cervical cancer counseling and vaccination. So before conceiving, they had to be given a chance for a vaccination. So the pap smear in the vaccinated group it was normal in 79%, and in unvaccinated group there was 90%, but there was increase in the abnormality in the unvaccinated group. So available evidence does not indicate an increased events linked to the vaccine in either the mothers or the babies after administration of HPV vaccine in lactating females. So many fear that if vaccinated during breastfeeding, their babies will get affected. So there are many studies which say vaccination will not affect both the mother or the babies during the breastfeeding period. Another study with 133 women, 1,133 women, during breastfeeding they were given vaccine or placebo, and they were nursing, and there was no adverse experience in the mother and the nursing infant in both the vaccination groups. So these are the guidelines in breastfeeding women. So by policy guidelines saying breastfeeding is not a contraindication for HPV vaccination, and ECOG says breastfeeding vaccine can and should be given to breastfeeding women aged 26 years and above, and younger women who have not previously vaccinated. And by WHO guidelines, breastfeeding is not a contraindication for vaccination. And by US CDC guidelines, the women who are lactating or breastfeeding can receive HPV vaccine. So HPV vaccine should be at least counseled to women in the postpartum period. So overcoming vaccine hesitancy at health clinics. So strengthening health education on HPV and HPV vaccination, finding appropriate ways to solve the problem of HPV vaccine and hesitancy. So we have to pediatricians were also given the study where pediatricians have to tell their patients regarding HPV vaccine at 9 years of age, and only 78% of the patients were favorable towards HPV vaccination when it was said by a pediatrician, and many were not comfortable to say that. So only 46% of pediatricians reported using HPV vaccine routinely or selectively. So it's up to other clinicians and gynecologists to increase the awareness about HPV vaccination. So beliefs of patient regarding effectiveness, only most of them don't know whether the vaccine is effective or not, and there were reasons for not getting vaccinated. There was cost effective. One Gardasil 9 is almost 10,000 rupees. So there are many, also 3 doses have to be given, so they don't want to spend money on that. So we have to counsel them. So even if it's costly, it's going to help them in the future. Health education programs can result in an increase in awareness of cervical cancer and HPV vaccination. So recommendations from physicians and healthcare professionals showed high level of acceptance for HPV vaccination. So during the prenatal visits or during pregnancy, when we counsel them about it, saying that it prevents risk of cervical cancer in the future, many are opting for vaccination. So this is another study done in Bangalore. The women in the third trimester were given during the antenatal checkups, they were given a questionnaire to assess the knowledge of cervical cancer and HPV vaccination and its role in cancer prevention. So before delivery, they did this questionnaire, and after delivery, they did a they had an assessment whether the awareness level have increased, and after delivery, those who were willing were vaccinated. During discharge, the first dose was given, and subsequent doses were given following the following visits. So we have to try some questionnaire like that, but it's quite hard. So physicians more likely recommend if they know the efficacy of vaccination only, many physicians are willing to give it to their patients. So health education played a major role in increasing the awareness of cervical cancer and HPV vaccination, and recommendations from the physician and healthcare professionals also showed high level of acceptance for HPV vaccination in postpartum women. So many young girls now they come and ask for HPV vaccine. So in the postpartum women also, the HPV HPV vaccination should be encouraged. So this is the Foxing HPV vaccine guidelines recommendations. So the optimal doses in 19 to 14 years of age, it is 2 doses at 6 months apart, and 15 to 26 years of age, it is given at 0 in 1 month or 2 months and 6 months apart, and 3 doses for older women till 45 years of age. So at 45 years of age, the efficacy is up to 60 to 80%. And in these women, the screening also should be done. So reduced dose, this is not given in India. The 1 or 2 doses at 9 to 14 years of age, and 2 doses for 21 years of age, and a single dose in girls 1 to 20 years of age. This is not recommended, it's not given in India. And in boys can be vaccinated from 9 to 26 years. 9 to 14 years, 2 doses at 0 and 6 months. 15 to 26 years, 3 doses at 0, 2 and 6 months. So summary, HPV is the most common sexually transmitted infection, and postpartum women are more susceptible to HPV infection due to changed hormonal milieu and decreased immunity. So at least after delivery, we have to promote HPV vaccination so that the risk of cervical cancer decreases. And also women after 30 years of age, despite giving HPV vaccination, screening should also be done.